So guys, so let's continue. So let's say we've got a circulation or circulatory failure. Circulatory failure. Guys, for the interns and the guys who are working now, medical officers, all those people, this topic, I want to repeat, this topic is not a high yield for medical students. Yes, you can get it on written here and there, and also on oral you can get it when you are discussing a patient. Because when you do oral exams, anything can be thrown. Yes, so it's not a very high yield for students, but when you are working, trust me, when you are working, this becomes a very crucial topic. Because, I mean, as I was doing family medicine, I did a lot of trauma cases. When we were on call, we would literally see trauma cases throughout. And when it comes to accidents, patients that are injured, when it comes to trauma, you should remember the sequence. The first thing that you want to do, the first thing you want to save a life. You want to save a life. The second thing that you want to do, you want to save a limb. You want to save a limb. An organ even. The third thing that you want to do, you want to reverse the pathology. You want you don't want any of that to progress. You want to stop progression of any problem, right? So when you have things like, so when you want to save a life, you must be systematic if you want to save a life. When you want to save a limb, you become more local. You focus on the limb. That's when you want to save a limb. You focus on the limb. You look at the limb. But if you focus on the limb before you were systematic, you're gonna lose a life and save a limb. So you want to save a life, you rather have a life that is preserved without a limb or a dysfunctional limb if push comes to shove. But you don't want to get these things messed up. And the issue about saving a life in the trauma situation, remember, A, B, C, D, this is saving a life. The airway, breathing, circulation, this is saving a life. It's all about saving a life. So you are systematic here. So the issue of look at circulation. This is circulation. This is circulation, and this is all about shock. If they are not in shock, make sure that you keep them out of shock. If they're in shock, you remove them from the shock. So that's circulation. So that's how important it is. I'm not sure if I'm over explaining it or what, but yeah, that's what I'm talking about. So when it comes to circulation, so basically, when a trauma patient comes in, what you wanna do is, yes, they've got a stab. Don't jump and look at the wound. Don't jump to the wound and be systemic. Look, are they talking? Are they talking to you? Are they breathing well? How is the vital signs? And all of that. So don't focus, because sometimes you can easily send a patient for an x-ray that is not stable, and then they pass on while they are going to the x-ray or while they are waiting there because you're not systemic. Okay, fine. So circulatory failure, you can have what is called pre-shock and shock. And in clinical medicine, this is what they want. They want you to think like a clinician. They want you to think like a doctor. So with pre-shock, this, if someone has been a volume depleted or whatever that is causing them to have circulation problems, this is where you want to catch them. You don't want them to get into shock. You want to catch them while they are still pre-shock. What is pre-shock? How do you say it? Pre-shock is that stage just before shock, that when they just have tachycardia. The blood pressure can be normal or it can be high. And if you use the blood pressure reading to judge how aggressive you're gonna resuscitate this patient, or how closely you're gonna monitor them, if you use your blood pressure, you are gonna miss pre-shock, because in pre-shock the BP looks normal. Your hint there is the tachycardia. So be worried about tachycardia, even if your blood pressure is fine, or even if it's high, but be worried about the tachycardia. Because, and clinically, I know when you read the book, they will say tachycardia is a heart rate of more than 100. But clinically, we use 115. 105, 110, we don't worry much. But once it gets to 115, that's when we worry. But personally, if I get someone who's got a blood pressure, tachycardia of 110, and they're actively bleeding, or they look septic, or if there's something that I can identify, that I can correct, then I will manage that patient. But if you see a patient at the clinic with a heart rate of 115, you cannot identify anything that needs to be corrected now, likely that patient is going to be fine. So in the pre-shock, these are the things that you must look at. Once the blood pressure is low, you are already here. You are already here. You are just about to miss the boat. That patient needs to be aggressively managed. The other thing that you can also pick up with pre-shock is someone, if you've got an APG, a mildly elevated lactate, right? But the easiest and the biggest thing that you must just look at is this guy, a tachycardia. Be worried. As much as tachycardia can be due to pain, nervousness, all these other things, but if someone is sick looking, be worried. If you give them something for pain, you try to calm them, they are still tachycardic, or it's just worsening, be worried. So that's pre-shock. Now, this is where you want to catch them, right? I will tell you about lactate. Why is lactate elevated in this kind of patients later on? Okay, so hypotension. So now when you get to shock, you are going to get other symptoms as well. Let's just do them according to, because remember, we said that the reason why we are here, the shock is not it's important to understand what shock does. Shock causes hypoperfusion, and if hypoperfusion of vital organs, and if you get hypoperfusion of vital organs, those vital organs which are vital to keep life, once they start to malfunction, it's gonna be a problem. That's what I want to explain. So we've got the brain, we have the kidney, we have the heart, we've got the bowel, we've got the we've got brain, heart, kidney, we've got the liver, we've got the lungs, right? We've got the lungs, okay. So we are saying that shock causes hypoperfusion of these organs, and when these organs are hypoperfused, what will they do? They'll start to malfunction. And how are we going to pick it up that they're starting to malfunction? The brain, that patient will start to be restless. That patient will start to get confused. That patient can get into shock, into coma, then they can actually die. Right? The kidneys start to become oligouric, later become anuric, because the body cannot afford to lose water through the urine when it needs water. So there'll be anuric, you're gonna have UNE derangement, right? So basically, let's just say pre-renal failure. Now you start having renal failure now, right? Your heart, once you get this, you get metabolic acidosis, and that metabolic acidosis has got negative effects on the cardiac output. So the cardiac output reduces. And once you get a reduction in cardiac output, you are getting into cardiogenic shock, and you are just worsening the shock that is already there. You might even get arrhythmias. Let's leave the bowel. Let's get to the liver. You just get derangement there, LFT derangement. Here, they start becoming tachypnic, shortness of breath. They start to be hypoxemic and the likes. Just from shock. Shock is not innocent. Okay. So this is how it would present. So guys, we don't want to get here. You don't want to get here. Let's say now we have so let's say now we have hypoperfusion. Hypoperfusion. The hypoperfusion causes multi-organ dysfunction and then multi-organ failure and then death just from shock. Just from shock. So, which means that when you've got a patient that has got shock and they have been in shock for some time, it's worthwhile investigating, taking bloods for this patient, doing an ABG, taking bloods to screen for the damage of those organs. Okay. Shock is not innocent. If you are you are working in the emergency department, you are in casualty, a patient comes in, step, MVA, that kind of a thing. If they are not in shock, there's nothing systemic about them, you are likely to save their life. You are likely to save if there's nothing systemic about them. Because the thing that actually kills is the systemic manifestations of all these things. Okay, so we have mentioned the types of shock. When it comes to okay, let's talk about one other thing that I forgot to mention. Once your patient now has got full-blown shock, on top of all those things that I mentioned, they will have a very high, very, very high lactate. Right? A very high lactate. Why does lactate go up when patients that have got shock? You expect lactate to be high in patients that are dehydrated, patients that are in shock for whatever reason. And the reason why lactate goes up is because even on the ABG, it's there. Sometimes you just be handed an ABG and then they ask you, what's the volume status of this patient? And then you say the patient is like dehydrated. And then someone who's junior will ask you, how did you see? It's because of the lactate. One of the things that you look at, it's because of the lactate. So lactate is a sign, or is secreted when tissues are hypoperfused. Okay, let's say this is our cell. Let's say this is our cell. This cell has got a blood supply to it. This blood supply is, in this blood we've got oxygen, we've got glucose. These are things that we need for the cell to function well. Now, these are normal circumstances whereby we've got abundance of oxygen, abundance of glucose. But now, if we have a problem, there's a problem with the blood supply, or there's a problem with some hypoxemia, so we are not getting enough oxygen, this cell will shift from aerobic respiration to anaerobic respiration. It's going to shift to anaerobic respiration. When a cell respires anaerobically, it produces a lot of lactate. So that's what I'm saying. A hyperlactatemia is a sign that you are hypoperfused. That's why you expect a lot of lactate in patients that have got shock. Because someone who's shocked, they might be breathing well, but the oxygen that they inspire does not get to the cell because of the blood that is depleted, the blood volume that is depleted. I hope you get that. So you don't want to produce, a normal lactate should be less than 2. Once lactate is about 1 point something even. So once your lactate gets to above 2, then you know that you are producing a lot of lactate, and because of hypoperfusion. I hope you get that. Let's quickly talk about so let's quickly talk about what they call endpoints of resuscitation. The endpoints of resuscitation. The endpoints of resuscitation. At what point do we say resus is done? We are okay, the patient is improved. Remember, there are different reasons why resus would be stopped. When a patient is demised, obviously, resus will have to be stopped. I'm talking about patients now that have improved. So at what point do we say resus has been completed, we are fine, we are happy? So the things that you look at lactate. Once you are resuscitating a patient and then you get a lactate of 4, lactate of 3, lactate of 5, 6, as you give the fluid to the patient, that lactate should start dropping to show that now you have corrected the intravascular depletion. Now hypoperfusion has been restored. So your lactate should start dropping. That's number 1. Number 2, a patient that comes in oligouric or anuric, they should start producing urine after giving enough fluids. So urine output is a second endpoint of resuscitation. Urine output. A normal patient should produce about 0.5 mils to 1.0 mils per kg in 24 hours. So in 24 hours, 0.5 mils to 1.0 mils per kg in 24 hours. That's a normal urine output, right? So the other things that help you to decide that you are stopping resuscitation is the general improvement of the patients. Look at the vital signs, right? And you look at the improvement of the organs. Are they improving? When you get a urine output alone tells you so many things. It tells you that you are giving enough fluids. The kidney now is starting also to filtrate. Now the kidney can actually afford. So the patient is being shifted from shock into proper hydration. So vital signs also become very important. Patients who need resus, they usually have abnormal vital signs. So the minute your pulse starts to improve, the minute your BP starts to improve, the minute your respiratory rate starts to improve, the minute your GCS starts to improve, then you can say, yes, we are winning in our resuscitation. So guys, I hope you enjoyed that. Thank you so much for watching.